Well, this song is dedicated to the children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe in me, rise on your feet and let's sing together. Yo, 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 yo.
Hey everyone, hi. Good afternoon, good morning, good evening, depending on what time you're joining us. You're welcome to another session of our Pata Reel. Just as we are warming up to start, please do get others to join, your colleagues, your friends, people you shared the webinar invite with. Please remind them that we are starting, and so they better join the moving train. Thank you for being an early bird. And just as our comms team is going to share their screen, we are moving along to discuss for our Pata Reel this quarter. So as you all know, you're welcome. This is Pata Reel, where we review cases, we engage with our peers, we have access to our experts, and we are able to learn lessons. Just to remind us that we are all service providers on the front line, and here things get real, because in as much as real is an acronym, it also just reminds us that the things that we do are real and that circumstances could get real. Those presenting today are coming from the clinics. And so you may hear someone presenting and a baby is crying in the background. Please, it's absolutely normal. We could have internet cuts. Of course, we are in a region where there are still issues with connectivity. So it's just to say that it could really get real. But we are going to have a beautiful webinar. So I think for our webinar today, it's quite interesting and exciting. Today we are going to be talking about viral load non-suppression, but there's a caveat to it. We are not just ending at non-suppression, we are linking it to issues of child protection, because we find that most of the times when children are not suppressed, there are underlying issues, some of which could include things that are done to the child that infringes on the rights of the child. And so for our session today, we've put together a beautiful pool of experts and presentations. We are going to be having two cases presented today. But just before that, to make sure that we are including everyone, we have translation available. So you can go to the interpretation tab. It looks like a globe, and you pick the language you're comfortable in. If you're Portuguese speaking, you can pick Portuguese. If you're French speaking, you can pick French, and just so that everyone is included. And just before that, I was saying that we've put together a great pool of experts today. And we do have Dr. Nandita who is online, and she's always been with us every Pata Reel, and her insights are always wonderful. So please look out and listen to her comments. We also have Madame Maureen. She's a child protection expert from Cameroon, and she is going to be supporting today as an expert. Thank you for being there, Madame Maureen. We have Dr. Filiuka, our very own Dr. Filiuka from Team Pata. all the way from Tanzania, and she will also be giving her expert views on the cases that will be presented. And for the cases to be presented today, we have two cases, one all the way from Tanzania. That's going to be presented by Dr. Rita. We are going to start with that case, and then the next case is going to be coming from Nigeria. And there's a slight substitution there. Ms. Agnes will be stepping in to present on behalf of Dr. Idowu, who is unavoidably absent. And so we have those two cases. And then after that, we have Ms. Faith from Tanzania, who is also going to make a presentation on child protection. So we promise you today is going to be packed with knowledge that you cannot afford to miss and your colleagues cannot afford to miss. So get on and invite them and remind them to take part. Without much ado, I'm going to welcome Rita, Dr. Rita from Tanzania, who is going to take us through the first presentation. Thank you.
Thank you, Dr. Vanessa. Can you hear me?
Yes.
Thank you. My name is Rita Makaranga, a medical doctor from a regional referral hospital in Dodoma, Tanzania, and I'll be leading you through the first presentation. So we have a case of a 5-year-old male child from Dodoma living with both parents. He is the third born in a family of 4 children. His mother is HIV positive, faces challenges with adherence to her own treatment. However, his father's status is unknown. The mother has not disclosed her HIV status or the child's condition to the father or other family members. She is self-employed and owns a pub, while the father works as a butcher. The child is enrolled in kindergarten and attends on regular basis. So the child was diagnosed with HIV on the 23rd of March 2023, and ART was initiated on 5th of April 2023. This was due to TB diagnosis on the time of HIV diagnosis. And also the HIV status of the remaining 3 children, the father and the grandmother, are currently unknown. Next slide, please. So during the time of diagnosis, which was on 23rd of March 2023, the client presented with poor weight gain for a month, which was accompanied with a recurrent fever, cough, and poor appetite. Nutritional assessment revealed a weight of 7 kilograms, a height of 78 centimeters. However, the mid-upper arm circumference was not documented. So the weight for age was less than -3 standard deviation, and the weight for height was less than -3 standard deviation, which was indicative of severe wasting. Following the complaints, he was diagnosed with severe acute malnutrition and pulmonary tuberculosis. Investigations, he did hemoglobin, for which the level was 7 grams per deciliter. He therefore had anemia. The CD4 count was 1,300 cells, which was 10%. The sputum for gene expert was done, which came out positive, therefore confirmed pulmonary tuberculosis. The serum CRAG was negative. So following the results and the complaint, he received treatment in the pediatric ward for 2 weeks and was later discharged. He was started on TB treatment and completed on 11th of September 2023. So the follow-up investigations, which were done on September 29th, 2023, hemoglobin level was 12, for which was an improvement from the previous results. The CD4 count was 492 cells, and the creatinine level was 44 within the normal range. AST was 12, which was also within the normal range. So currently the client is stable, and the most recent nutrition assessment, the measurements were the weight of 13.5 kilograms, a height of 89.9 centimeters, and the weight for height was a positive 1 standard deviation, which is an improvement from the previous measurements. So this slide shows the trend of the weight gain of the child from the beginning of treatment on 2023 to currently. There has been an improvement, which is not very significant. However, it is still an improvement to currently from 7 kilograms to 13.5 currently, which was February this month. So the nutritional status of the child is improving, however, not to the level that we do expect. So the child could be having chronic malnutrition. So following the diagnosis on the 23rd of March 2023, and the initiation of the antiretroviral therapy on the 5th of April 2023, he was started on the first-line regimen, which was abacavir, lamivudine, and dolutegravir, to which he continues to receive to date. In the viral load history, on 29th of September 2023, with the first regimen, the viral copies were 51,247 with a CD4 count of 492. So this was indicative of high viral load, and EAC was initiated. And the barriers which were identified was that there was poor adherence during that time. And the reason being was the mother was administering medications in late hours, for which most of the times the child was asleep. So this was addressed by changing the time of giving the client medication, for which the mother agreed. On 11th of September 2024, viral load was then done once again, and the viral copies had not changed. And so therefore the child had a persistent high viral load. So this hiatus from 2023 to 2024, EAC was done, however, was interrupted as the mother missed multiple appointments. But on follow-up, she came back at around May 2024, for which the EAC was reinitiated and viral load was then done. However, the results were still not convincing, and the barriers that were identified was still poor adherence. In this case, the reason for poor adherence was that the child was staying away from home, living with other family members who were not, for which the disclosure was not well done, and therefore adherence to treatment was not possible. On March 2025, there was still a persistent high viral load, for which in this case it was double the previous results, and it was a significant rebound of viral copies. It was still indicative of poor adherence, and the reasons still being the same. So the medical interventions and course of action following those results, the client continued with ART and EAC continued too. However, there were frequent interruptions. Nutrition assessments have been conducted in every visit, and also a linkage to social welfare and psychologists was done. However, the mother was not adherent to appointments, therefore there was still an interruption. Another challenge is also that the mother is still uncooperative to treatment. Next slide, please. So the current challenges that we're facing is that we have poor support from the caregiver, which is the client's mother. But another challenge is the non-disclosure to supporting family members, as the mother's condition together with the clients is not known to the husband, who is the client's father, together with other significant supporting family members. And we also have had a difficulty in conducting index testing, since it was difficult to approach the family members without the knowledge of what exactly is going to happen. And we also had a limited psychosocial support. As for the lessons learned, a consistent caregiver engagement and disclosure are very critical in maintaining adherence and achieving virus suppression. But also, a non disclosure to family members significantly undermines treatment continuity and complicates the psychosocial support. Nutritional monitoring and psychosocial support must be integrated into routine care, especially when the caregivers are uncooperative. Thank you. So the questions for the experts, the first question is, how can we navigate the mother's lack of cooperation and non-disclosure to establish a reliable support system for the child? But also, what is the best approach for conducting home-based index testing for the rest of the family without compromising privacy and ethical boundaries? Thank you.
Thank you very much, Dr. Rita and Team Tanzania, for putting this beautifully together. Again, if you're just joining us, you're welcome. I understand that some people are facing challenges with the Zoom app, so we are trying to resolve that, and it will be resolved. Today, we are talking about viral load non-suppression in children and adolescents, but also looking at the very important aspect, which is on child protection. And we've just come to the end of the first case, which was of a 5-year-old from Tanzania who faces issues with viral non-suppression, largely due to non-disclosure of the mother to significant orders. And right now, we are going to hand the floor to our experts. First, we are going to hear from Dr. Nandita, and then from Madam Maureen, and lastly from Dr. Filiuka. And they're each going to give their perspectives, but also provide some elements of responses to the questions that the team in Tanzania has raised. Thank you, Dr. Nandita, you have the floor.
Thank you so much, Dr. Vanessa and Dr. Rita. Thanks for sharing that case. I think we see a lot of cases like this, and this was a really, I think, a really good one. I want to point out a few things on the clinical side. I think the history is very telling that this is the third born child. And though he has been diagnosed and on treatment, mom is also not adherent well, and the father and other siblings have not been tested. So we know that disclosure and partner testing and index testing are all things that we think about in terms of supporting families, but we know that these are the challenging issues. Some of the, I want to point out the strengths though of this case as well, or the strengths of this family, and that, number one, I want to point out that this child is actually enrolled in kindergarten, so is in school, which brings up the question of, how is he doing in school? What are the resources available to him through school as well? But just also looking at the history in terms of when he was diagnosed. I think the clinicians managed this case very well. He was initiated very rapidly with the regimen that is the standard of care. And we looked at his, dosing by his weight and treatment for malnutrition. A couple things that I want to notice when we looked at the viral load, particularly since we're talking about treatment failure or viral load failure. And that's really what we can see when we follow viral loads over time. Now, one of the things that I noticed is that if we go back to the slide where the viral loads were included, that the first and second viral load were actually the same number. And that may have happened in real life. That may just have been a coincidence. But sometimes what we find also is that when results don't come back, we still want to review and use the last viral load that we had. And so I think it's really critical that that was still documented and that was still reacted to. So as much as it may or may not have been a repeat viral load, at least at that point, the clinician took the time to look through the viral load results, document something, and reinitiate enhanced adherence counseling. But the other thing I want to just mention briefly, and this is maybe a question for the team, is and to think about as we see cases like this, as children are coming in, many of them come in malnourished. And as they receive nutritional rehabilitation, they gain weight quickly. And sometimes what we see is that we forget that the dose has to be adjusted according to weight. And in some cases, we've seen that viral failure can actually be caused by the dose being too low. So one of the things when we're faced with, these situations is to really go through what could the different issues be. And I think poor adherence and some medical neglect may be an issue here, but there are other things that we can also think about, like making sure that the dosing is correct. But really looking at this case from a clinical standpoint, it has been relatively successful. So the child is on treatment and still in care, as much as he may not be brought regularly to the clinic. So I think that's really a concern. And in thinking about how do we navigate the situation? Thinking about this mother, we describe it here as a lack of cooperation. But if I think of a mother who is working in a bar, who is taking care of children at home, who is not disclosed to her own husband, that is a challenge, that she is in a challenging situation herself. And I think this is where some of our role as healthcare workers is also to support caregivers and make sure that we are supporting her and what she needs and understanding, really understanding, uh, uh, what is happening in the family. So I think this is a chance for us to think about allyship with caregivers and parents as number one, that's really who is responsible for the child. And secondly, again, I think many caregivers really struggle. We know disclosure is an issue. We know that, partner disclosure in particular can be challenging for many women. So that is really something to work alongside the mother with. But with regard to the second question about the best approach for conducting home-based testing, I'm really curious to, hear from the other panelists how they would approach this. Again, I think this is an issue where it's not easy to just walk into somebody's home. But again, it's about building trust in a relationship. And when it comes to home-based testing, particularly for things when it comes down to like partner disclosure and testing, one of the things absolutely important to screen for first and foremost is to screen for interpersonal violence, IPV or domestic violence. And that's absolutely necessary to make sure you engage the mother and discuss with her the practicalities of doing this. And I think there are other steps after that. But with that, I think I'm going to keep it brief, Dr. Vanessa, and share the floor with the other speakers. Thank you.
Thank you. Thank you. I'm going to hand the floor. So just before handing the floor to Madam Maureen, I think what came out strongly from your feedback was that caregivers need education and we need to accompany them even as they accompany their children. And more importantly, we should screen for IPV risk. Thank you for that. Madam Maureen, you have.
Whenever it's my turn. Can you hear me?
Yeah, why don't you go ahead? Yes, I think we lost Dr. Vanessa for just a moment, but if you could go ahead. And are you able to turn on your video?
Yes, I can.
Oh, wonderful.
Okay.
Now we can see you.
You can see me now, right?
Yes, we can see you.
Okay, so thank you very much. Okay, thank you so very much for the first presentation. The story is quite interesting and it looks very similar to a case at hand we have actually battled with here in Cameroon, particularly in the Northwest region. And we are still working on the case because when you start getting the scenario that the doctor has painted, you see how ramified this case really is. A woman in a relationship where she is unable to disclose her status and definitely cannot be able to disclose the status of her child, which puts both herself and the child and maybe even the rest of the family at further risks. So when we had a case that is really similar to this, we tried to look at the socio-ecological approach to handling it, meaning that we wanted to see how we could find ways of supporting from the very from the initial contact, which is actually the mother, to understand her realities and how it was affecting the well-being of the child and all of those. Now, complexities will come in because when we look at what has to be done, how it is done, and that if it is not done, what next will happen. So sometimes you start seeing things that may be showing up like punitive measures. If you don't take care of your child, if your child's viral load goes high, it means you're negligent. Of course, what is true to a point, but drawing that fine line sometimes becomes very challenging when you start looking at the woman's reality. And so, like the previous speaker said, was like, there is need for us to try to do further assessments to help us understand the reality in which this woman lives. What are the stakes? Are they even necessary? We equally would want to do further support through psychological assessments, because sometimes the people may be going through they may be having other personality or psychological challenges which could hinder them from being able to find the support that they need or to become authentic with self. So empowering at this point becomes very, very crucial, which sometimes it does not come easily. I'll put the case in time we've been struggling with. After doing some psychological assessments, we understood that this woman is, I would say she's neurotic, and I would say that she is a little bit paranoid and very dependent. She has a dependent personality disorder, meaning that she cannot find herself living without a man, but at the same time, she doesn't know how her results, if it's told to this man, is going to affect her relationship. So she is struggling with this issue and battling with it and looking for other names of what is happening with the child to be the child's issue. Meanwhile, the medical team knows exactly what the issues are. So after even doing the assessments and understanding her psychological limitations and her personality traits, we have been struggling to see how this woman can be engaged, you know, to care, psychological care, and it is still challenging to be able to get this woman on board. You know, at one point, after the hospitals had tried and they found it difficult to support, and child protection came in, we tried giving her education and even called out for the 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 ministry in charge of social protection to come in, and we try to help her see the rights of the child and how she could support, in improving the quality of the life of the child, particularly the health care. So with these things that we have attempted to do, we are still meeting with a lot of, I don't want to call it resistance, because I don't want to think that this woman willingly doesn't want to take care of her child, but maybe she needs further support to be able to take care of her child. And we are still caught because we are in the space where this child is already about 13 and needs disclosure. The child doesn't know the status. And we are still caught up with confidentiality, not going to break up confidentiality because we are trying to look for some other person who can support, for the child to know their status and for the child to actually be followed, uh, to be followed correctly to pick up medication and take medication in order to suppress the viral load. So when where we are right now, what we are looking at is what the state can do, because when we look at the guiding principles that are there to support us in child protection, one of the strong guiding principles that cuts across the United Nations Convention on the Rights of the Child, the African Charter, and even our own local constitution and our penal code, I mean, in Cameroon, you would see that the best interest of the child is what we should always look out for when we are dealing with children. So the big question that we are having right now, and we are putting it to all of us who are working within this sector of HIV, understanding the place of confidentiality and breaking of confidentiality and all of those, we are looking at it and asking ourselves, if we were to do something different to look at the best interest of the child, so that this child does not lose the chance of surviving or of living, what can we do? So the best interest of a child definitely would warrant for us to look for other solutions away from the mother, who in herself is vulnerable and needs protection. And now it puts it a little bit more complicated and difficult, because when you want to go away from what we are traditionally doing, it may have a lot of other ramifications or consequences, maybe at the level of the family, at the level of the woman in question, and maybe even the health of the child. Because if we were to take time to look at that woman in question, she even if the family gets involved and she loses her marriage, that child may still be at risk of neglect. The child may not still be able to receive care, because maybe she'll abandon the child, because the child may be depriving her of the thing that gives her the joy of being a woman, which is marriage. Because people have different things that, that they've attached a lot of significant value to. So when we have this, I think that we are in that space where we need a lot of conversations, looking at it, especially looking at the best interest of the child and asking ourselves, how can we do this? It gets better.
How can we do this?
Yes. How can we do this? And I'm sure it can actually get better.
I think
when we understand.
Yeah.
Yes. Somebody just
Yes, so
called my attention.
Yes, I was going to say that maybe how can we do this better? We can bring this back when we get to the question and answer session,
Okay.
because it's quite interesting. And just as you were speaking, I was actually asking myself a lot of questions. Yes, this is difficult. We need to consider the mother. We need to consider her own rights. We need to also consider that she needs protection. So I think we can bring this back to when we have the question and answer session, and we have a little bit more interaction around that. But I love the fact that you were able to share an experience, which is a lived experience. And again, just goes to show us that this is real, guys, Pata real. I mean, we are discussing real cases, and we all have these experiences. So thank you very much, Madam Maureen, for giving us those insights. There's a need for more psychosocial support, and also there's a need to better understand the family dynamics. That's what I picked out of your intervention. And right now, I'm going to hand the floor to Dr. Filiuka very quickly for your intervention before we move to the second case. Thank you.
Yeah, thank you so much, and thank you for Rita for the presentation. This is something that we need to really think about on how we can navigate most of these cases that are in our society, and we are struggling how to deal with it. For me, looking at this, as Nandita say, at the clinical part, we need first to consider with the weight gain and the dosage. That is part of the something that we need to really think around. And then one of the they are very good factor here. Looking at the child is already at a kindergarten, so perhaps we can also look at it, what if we can make sure that we progress it through our support from social worker, that we can approach the kindergarten and this patient, this child could continue taking medication, because that high viral load with that age it's very high, and the health outcome of that will be not as good. As I hear from other panelists that we need to think into three things. We have a child, we have a mother, and we have a family. And this is mostly is a socio-ecological model. And one thing that we need to focus on is the mother, because the mother is the one who knows the significant people, is the one who can change. So our effort should be on the mother. So when is she attending at the same clinic, receiving her medication on that same clinic? If that's so, then we can start arranging the sessions with the mother, starting with mental health screening, understanding her situation. I understand that she is in a very tight job, having a bar, and maybe sometimes she's cooking. So most of the time she's also busy with that work, forgetting what is happening at home or what is happening to other people. So understanding that is, we need to do the mental health screening for the mother, looking at her adherence as well, if it's also a stable adherence, and then we can use that to encourage the mother to make sure that her child is also adhered to the medication, because how healthy the mother is. And additionally, since we have a social welfare system, then this is it's a good case to refer to the social welfare system, whether at the facility, and then at the facility we'll start investigating at home, looking at IPV or any domestic violence around, because she hasn't yet even been disclosed to the husband, so or to the father of the child. So we need to understand the environment she stays, what environment is the child also stays, who is looking after. So with that, I think most of the thing that because we have a very good system of social welfare, then we need to really refer the case to the social welfare and making sure that you follow up, like Rita, following it up to the social worker. Social worker will communicate with the ward social worker, do a social assessment on the environment and other things, so that we understand, we get a clear picture on what's really going on at home. And there is, we know how we can understand how to approach and how to deal with that without causing any more trouble around that. Because I know the time is not on our side, and many has been talked to. So I'm just going to leave with this, and then we can discuss during the Q&A. Yes, thank you so much.
Thank you very much, Dr. Philly. Again, going back to understanding the context and doing a deeper dive. Thank you for that. I'm sure Rita and the team in Tanzania now have a lot of information that they can use to better the care of this child. Again, we are going to have a lot of discussions, and I'm inviting the case presenters to stay on. Just so that when it's time for these exchanges, maybe there may be people in the crowd who want to ask questions and you can answer. But then there's also the Q&A box. So if you have questions, feel free to drop them in the Q&A box, and we'll also respond to them. If you're just joining us again, we are discussing viral non-suppression in children and adolescents, but also looking at aspects of child protection and how they sit rightly into helping children get suppressed in their care journey. And we've just concluded now with the first case, and we are moving on to the second case, which will be presented by Miss Agnes from Nigeria. Agnes, you can hear me, you have the floor. While Madam Maureen, please, if you don't mind, mute your mic. Thank you.
All right, thank you so much, Dr. Vanessa, and good afternoon, everyone. My name is Agnes Dovera, and I work with African Network of Adolescents and Young Persons Development, ANIDE, one of the community partners in Nigeria implementing the Impact for HIV project, and I'll be presenting on behalf of the Nigeria team. Thank you. Next slide, please. Okay, so we'll be going over the client history and the family circumstances. It's a case of a 19-year-old male residing in Lagos, Nigeria. Lagos is a state here in Nigeria, who lost both parents to unknown illnesses. We're thinking most likely AIDS during his childhood, and now lives with his aunt, who serves as his primary caregiver. He was first diagnosed and initiated on first-line ART, antiretroviral therapy, at age 8 in 2015. His disclosure of family circumstances. His HIV status has been kept largely secret from peers and the wider community, driven by fear of stigma and even social rejection. While his aunt is his primary caregiver, she has been unable to provide a consistent day-to-day oversight, leaving him largely unsupervised in his treatment routine. His status was not properly disclosed to him. He found out himself as he grew up into adolescence, and because of this lack of structured supports, it has had significant impact on his ability to adhere to medication over the years. The family's social and economic status. He has no independent income. He's entirely reliant on his aunt's limited financial resources. These constraints have also made it difficult for him to attend some clinic appointments consistently, also afford transportation costs, and also access adequate nutrition, all of which are critical enablers of this treatment success. The compounding effects of the poverty, social isolation, and psychological weight of a lifelong diagnosis has made him deeply vulnerable in this position. This young male dropped out of school in JSS3 as his aunt was struggling to pay his fees. Because of the financial constraint they had, they were struggling to pay his fees, so he dropped out of school in JSS3. His clinical presentation and diagnosis. He was presented to the adolescent HIV clinic at the Lagos University Teaching Hospital on the 18th of September 2025 with persistent fatigue that had worsened over recent months. Noticeable was weight loss. There was oral thrush, the only documented recurrent infection. Upon physical examination, he appeared underweight and malnourished. He was screened for advanced HIV disease and was confirmed as a patient living with AHD, which was also further complicated by his high viral load and poor adherence. This is a finding that was consistent with his low CD4 count of 142, the oral thrush, and prolonged history of virologic failure. While there are no records that exist, such as for additional investigations like full blood counts, blood culture, or liver function tests. For clinical findings, the investigation at admission confirmed a viral load of 75,000 copies alongside a low CD4 count of 142, and poor ART adherence over 2 to 3 years was identified as the primary driver. His treatment journey. For several years, adherence was relatively maintained because as he entered adolescence, engagements with care deteriorated. And this could be likely due to the non-disclosure, as he had to find out on his own as he approached adolescence, and also neglect from home, dropping out of school, now compounded by alcohol use, which made adherence poor. Part of what was also observed was there were cases of substance abuse from these adolescents. And this poor adherence has also led to persistent high viral loads, despite intensive adherence counseling, ultimately leading to his switch to second line with 3TC, abacavir, and epivir. Next slide. This is his viral load history. Upon admission in 2015, he had a viral load of 750,000 copies. His CD4 count was 142. For his ART regimen, he was on zidovudine, lamivudine, and nevirapine. He was on this ART regimen from 2015 up until February of 2019. His viral load as at September 2017 was 75,000 copies with a CD4 count of 169. And in December of 2017, he had a viral load of 444,336 copies with a CD4 count of 244. And in August of 2018, he had a viral load of 52,035 with a CD4 count of 781. And in February of 2019, he had a viral load copy of 273,529 copies with a CD4 count of 142. And in February of 2020, he had a viral load copy of 75,200. In October of 2021, he had a viral load of, in February of 2020, his IRT regimen was TLD. He was on TLD from February of 2020 to March of 2023. In October of 2021, he had the viral load copy of 210,000. And in March of 2023, he had a viral load of 248,000. In September of 2025, he was switched to second line, and he had a viral load copy of 87,505 with a CD4 count of 458. And in 28 January of 2026, he had viral load copies of 24,600. He was switched to second line with a combination of abacavir, lamivudine, and atazanavir boosted with ritonavir from 2025 to date. This is just a graph that is showing us his viral load trend. You could see the graph that goes up shows when he presented at the facility with 75,000 copies. It's not been consistent, but in 2026, January of 2026, he has a copy of 24,600. Next slide, please. These are some of the interventions which I've largely spoken of, interventions that Lutz have done, and I've spoken more into it when I spoke about his treatment journey. Next slide, please. Some of the challenges and lessons that we've learned from this case. One is, amongst the challenges, stigma and enforced secrecy deprived him of open community supports, and over a decade of treatment generated medication fatigue that eroded his motivation. Also, the absence of caregiver supervision created an environment where missed doses went unchecked. Currently, this young person, there are times, even despite clinic follow-ups, they are not able to reach this young person. Even his caregiver does not know his whereabouts. He goes months without being able to be traced and returns at will. And this has also affected his has made some of his doses to go unchecked, and also resulted to poor treatment adherence. Also, financial hardship ultimately forced a premature discharge from the Lagos University Teaching Hospital, and substance use also added further clinical and psychosocial complexity. While AHG screening was conducted and confirmed, as I already mentioned at the beginning, some important investigations remain undocumented, like the full blood counts, the blood culture, and the liver function test. And then lastly, there are no documented linkages to OVC programs or community-based organizations at any stage of his care. That could have provided a pivotal vital psychosocial, nutritional, and even financial support to both him and his caregiver. But some of the lessons that we've learned so far from this case is that full blood counts, liver function test, blood culture, intensive adherence counseling records, and resistance testing should accompany every regimen switch. And also, substance use, including hard drugs, must be routinely screened for, as it has direct implications for his ART regimen safety. And also, lastly, the need for peer mentorship, caregiver education. I think I'll say continuous caregiver education and OVC linkage must be embedded from the start. And also, social protection mechanisms must exist to prevent poverty-driven treatment abandonment. Next slide, please. We have questions for the experts. One is, this client has experienced virologic failure after more than a decade on ART, driven by a complex combination of medication fatigue, stigma, inadequate caregiver supports, and alcohol use. What evidence-based adolescent-centered strategies have proven most effective in managing virologic failure in young people, where psychosocial barriers are the primary driver? And how can this be implemented in resource-constrained settings like the Lagos University Teaching Hospital? Secondly, as young people like these clients transition from pediatric to adolescents to adult care, continuity is frequently disrupted. How can adolescents, health clinics in resource-limited settings better integrate caregiver education, structured peer supports, and community-based follow-up to ensure that young people maintain viral suppression through this critical transitional period, and who should be responsible for coordinating this? And lastly, mental health. Mental health has become an integral part of programming for young people, especially young persons living with HIV. So as mental health has become a critical component for young persons living with HIV, how can screening for it be properly integrated into treatment protocol, particularly for young adolescents? I think this is my last slide. Thank you.
Thank you very much, Agnes, and thank you for walking us through this very interesting case. If you're just joining us, we are still speaking viral non-suppression, but also looking at aspects of child protection. And so just before I give room to the experts, I would like to say it's not late. Please get your colleagues and friends to join us as we go along in this journey. So we've just listened to a case of a 19-year-old who had issues with disclosure, which was then compounded by some degree of neglect at home, and now he's into alcohol and drug use, which is in a way affecting his viral suppression. And so the case has been presented, and right now I'm going to give the floor, beginning with Dr. Filuka, then Dr. Nandita, and finally Madam Maureen, so we can have inputs from our experts. Thank you, Dr. Filuka, you have the floor.
Yes, thank you so much. This is a very, very complex case, and it's a case that has been already been intervened. I can see the psychosocial support and other clinical medical support that he was receiving, and yet we're still struggling with his outcome, and how can we attract him to continue with the treatment and self-manage himself with this. So as a mental health specialist, and most of my research is around transitioning period, I'll try to see whether we how I can at least answer the second and the third question that you've raised, Agnes have raised, the Nigeria team. So looking at the transitioning period, first of all, 10 years ago, we were struggling how we can define the transition, when these young people should move to adult care, and how will it be? So if you research on, so many people have been writing on this. For example, for Kenya, Juguda is writing, and right now she is on she's doing a clinical trial on providing some intervention around transitioning period so that we empower these young people to self-manage. We try to reduce the mental health constraints with them, as well as making sure that they are ready to stand on their own and being able to support themselves the way they are at that age. And remember, this adolescence period is a period where people are starting being aware of their HIV status, aware of their problems, aware of their surroundings, and also trying to experimenting so many things, drugs and other things as well. So with this, I can understand where Luth is going with experimenting, and sometimes they end up with maladaptive behavior like he is with alcohol use. But sometimes that alcohol use could be a problem, it could be a self-medication to him for his mental health challenges. So first thing that I will share my experience. We try to pilot the mental health screening, especially for the adolescents with persistent high viral load. And that screening is a digital screening, and it's a short, very quick and short, so that the health providers are not burdened to do those screening. So we digitalize because it's easy on the phone, you can have it. And we instead of using PHQ-9, GAD-7, and PTSD scale, we reduce them to PHQ-2, GAD-2. So we reduce so many questions to very few questions. So once they're screened, and then we created a referral strategies that once screened, they can be taken to the social worker at the facility, and social worker will do more screening, social screening, and investigate. And then there, if it is more that they need a psychologist or a psychiatrist, then they'll be referred to a psychiatrist. As we know, in most of our African country, we have very few mental health specialists in our community. So with that, that's how the screening is going. But during the transitioning, we are trying to add in some intervention. For example, intervention of accepting the HIV status. Once, especially encouraging all young people needs to be disclosed with their HIV status, understand the knowledge of HIV status, and as well as trying to looking into self-care, self-manage. When they come to the clinic, they need to really speak up about themselves. That's why we engage them with peer-to-peer support. We have a group session so they can share their problems, and it is easy to learn through that. So there are different programs which yet most of our governments have not yet embedded them into the government system, but we're trying to see how we can persuade most of the governments to make sure that those interventions are in, so that we can support these young people through the adolescence period and become a better person and manage themselves during the adult care. So with the viral failure, I'm raising the questions that most of the time I've seen that through past 10 years, he has been changed to different medication and changed back and changed forward. I'm not sure whether did we investigate it? Was there a resistance, or was this just merely an adherence problem? So if it was merely an adherence problem, I was wondering if that was worth doing it, or trying to see how we can support this person to engage themselves clinically before changing the medication. So by saying that, I will leave to Nandita, it's more clinical, and then if we have more mental health questions and all that, then I can share some links. Some people have done the good work especially in Zambia, Kenya, and Nigeria itself. There's one of the author also reported the way how to deal with these young people during transitioning period. Thank you. Thank you so much.
Thank you very much, Dr. Filuka. Just before Dr. Nandita comes in, I think the child was actually changed once and optimized once. So I think in 2019, there were a lot of children who were initially on nevirapine-based regimens were optimized to TLD. So I think that's what happened in this child, and he was recently switched to second line. That was in September 2025. From the history, I just wanted to clarify that. Thank you, Dr. Nandita. You have the floor.
Great. Thanks for clarifying that, Vanessa. And I'll come back to talk a little bit about viral failure and what we see, from his history. But I want to congratulate the team for presenting this case. This is again another complicated issue, and adolescents we know can be very challenging because they have a lot of needs, and adolescence itself is a challenging part of life. I do want to say, this is, in some sense, this case also shows us the strengths of our HIV program. I think there was a note there that we had lab tests like viral load and CD4, but other tests were not missing. So we've really had a strong HIV program that's given us, systems that even to this day continue to work. Now, with this case in particular, in terms of his treatment, I think we all have sort of a shared history of remembering the different regimens that we've transitioned through the years. And so this young man was initially actually suppressed on what we now consider to be a suboptimal regimen, which is AZT, 3TC, and nevirapine that was in one combination tablet. That's a twice daily regimen, and it's one that we can become the virus can become very quickly resistant to. So I noticed then that he was switched to TLD, which was an appropriate switch at the time. We transitioned many people who were on older regimens to TLD, which is much simpler to take and a much more potent and durable regimen, which means it does not develop resistance very easily. It actually takes quite a bit of time. Though we do see some dolutegravir resistance, we're not seeing it anywhere close to how we used to see resistance in the era of using nevirapine and efavirenz. So one of the questions I do have, I think, is a little bit about this recent switch to second line, which included abacavir and 3TC, which is available in a large tablet combination-wise, but also with atazanavir, which is a PI, but it's also a separate tablet. And so, but that said, I would want to think a little bit about adherence and whether that was the issue or whether it was resistance. So I think our ability to distinguish between what is an adherence problem and what is actually resistance is now very different than what it used to be. I think we've also raised the issue of substance abuse. And, Dr. Filuka made a comment about how this is something we need to screen for. And absolutely, I think once we start seeing adolescents, we know that substance use is a part of the world, and adolescents frequently come into contact with it. There's a difference between substance use and substance abuse. But at this age, I think, we also have to understand the history of this young man and where he's coming from. And we have to ask ourselves, what does that alcohol use indicate? Is it a response to trauma? Is it him trying to leave behind his negative feelings? There's lots of reasons why adolescents turn to substance use, whether it's alcohol or drugs or other substances. And so I think asking in a non-judgmental way, sort of incorporating screening into your regular practice is actually a good way of knowing what's happening, but also being able to then share this in a non-judgmental way, in a way that adolescents understand it's out of caring and concern that you're asking, not out of saying that there's something wrong or something bad with the practice. But that said, it is concerning that he's using alcohol, and we'd want to know a little bit more about that and follow that as well. sometimes some of the ways that I will say it is I'll ask casually. For very young kids, I'll ask them about their friends first. Do any of your friends drink? We know that adolescents tend to be very curious, so we can ask about their curiosity. And again, it's making sure that they feel safe and comfortable to share with you what's happening in their lives. And they can do that when they know that you will be supportive, not judge them for their behaviors, and understand where they're really coming from. Um, but in terms of what we could suggest for this young man at this point, I think we've already heard a little bit about his disclosure history, and that history is really, again, was he found out on his own. He wasn't formally disclosed to, and so that again gives you an idea of what this young man has been through in his life. We know that disclosure is actually a very a critical issue, and no matter how often you do it, it doesn't always get easier. But we do have approaches for how do we disclose, or how do we make sure we reset the conversation so that he has an understanding of HIV that's not so negative, that he understands what the potential is, what the purpose of his treatment is. And I think peer support is actually critical in this case. Now, I don't want to suggest that peer mentors are a replacement for healthcare workers or for mental health providers in particular. That's not their role. But their role really is to be there as a support, to be able to speak in the language that the adolescent understands, to be less threatening, but to really be there as a support. I think our position as healthcare workers is, again, to really make sure that this young man is connected to peers and to other support systems, whether that's educational or occupational employment, whether that is support for food assistance. So really figuring out what are the social services, but then really linking him to other peers who have that shared experience. And that will hopefully normalize what he is going through, because it can be very isolating to not disclose, and to hold that, for him to hold that himself. And the last thing I want to raise is that now we're talking about this child as an adolescent, or this young man as an adolescent in pediatric care. But he's technically, legally an adult. And I think that's another thing that I think we come up against when we talk about adolescents. What are the laws around adolescents? Who is really responsible here? Is it the healthcare worker? Is it the parents? Is it he himself? And so I think these are some of the things that we have to think about. But again, I think it's a challenging case, but really illustrates, what we now have to turn to. I think the medications and the clinical care can be challenging, but most often it's relatively straightforward. And we have good medications, we have good lab tests that are available. But these issues around growing up with stigma and shame, not having the resources you need, having issues with malnutrition or education, those are the real problems. And I think I saw Ed Wick had put a comment in about this, about a previous case, sort of expressing that these are very typical, and sharing that, in one of his cases, the mother changed her address, changed her phone number, and disappeared. And again, that shows you the amount of stigma that people feel. So we really have to think about how we approach these cases. I think the importance of psychosocial care and really understanding what support systems are out there are critical. And this is, I think, our next stage in the HIV response is to think a little bit more about these issues. So Vanessa, I'm going to stop there so we can have a little bit more time for discussion.
Thank you, Dr. Nandita. And I'm going to hand the floor to Madame Maureen. But what I hear you say is, how can we now just normalize the HIV discourse? Because stigma, is a real killer. So thank you very much, Dr. Nandita. Madame Maureen, you have the floor. Thank you.
Okay, thank you very much, Dr. Vanessa. And thank you to the two previous speakers. I think that our minds are actually just working in harmony with the case that we've just had from Nigeria. As as hard breaking as it is that we see young people who may take a lot of things into their hands, the one other thing that I may want to add to the lots that we have actually talked about is that truth be told, when you're looking at the developmental stage of an adolescent from a psychological point of view, they are in that age where they are in between, especially from maybe Erik Erikson's approach, you would see that at the age of this young man, he's caught in between identity formation and role confusion. So a lot will be happening in the inner world of this young man. And he needs a lot of support and guidance, maybe since his parents are not there. And he's on and off with the aunt that is the caregiver at this point in time. It's important that we ask ourselves, I mean, what can we do with young people who are in this transition, struggling with role confusion and identity, trying to find the models, trying to even be able to process what is happening with them? Because even at this point in time, when you look at their brain development, we would see that parts of their brain actually they're still struggling to grow. And so at this time, there is need for a lot of support that may come either, unfortunately, his family may not be able to do that because they may not just be able to do that, but there is need for the family to be available to provide him with support. I know that for the HIV program, we have the peer mentorship programs where we could have other peers that can support an individual. But but the case of this young man, I think is a little bit way above the level of the peer mentorship, because we are seeing that there are very clear psychological processes or developmental events taking place within this individual that may need some level of specialized support. And of course, with the absence of those support systems, it becomes a little bit very, very tricky, because the individual needs a team kind of support to be able to navigate. While we are looking at the social aspects, we are looking at the medical aspects. We should be looking at the possibility of really introducing psychological support to this young man or other adolescents who may be in situations that can identify with this case in time that we are talking about. So club activities could be good as well. If we could have club activities where we can have them come with creative ideas that can make them to become more comfortable, it would be good. We may equally want to see how we seek other support from other organizations, because when I hear this case, I get a situation where we don't have any organization that can be able to provide any further support, be it financially or otherwise, to an individual like this. So there is still need for us to try to see how we can source for support that can come in and help leverage the efforts that come from the medics who are making sure that they provide the best medication and best test labs or equipment to support us understand what is happening with the child, and to see how we can make sure that he is able to navigate this in a more I would say in a more facilitated way, because there's a lot of need to co-facilitate and support this individual at different levels. That's just what I'm going to add to what the other speakers had said. Thank you.
Thank you very much, Madam Maureen. And one thing that's loud and clear from what they've said is we have to be advocates for the children and adolescents we are serving. And adolescence comes with its own issues. And now going back to the point of us being advocates, at the beginning of this webinar, I did say that there are two components to it. We are going to be having or talking about the non-suppression and looking at how it links to issues of child protection. Right now, with this stance of you being an advocate, I think the question that lingers is, how do I advocate for somebody, or how do I take the right steps to make sure that the child and adolescent I'm working with have their rights preserved and not being cheated out of healthcare, which is which is their rights essentially. So right now, I'm going to hand the floor to Miss Faith from Tanzania, she's a child protection expert, and she's going to give us some tips or some of the things we can do as service providers to help these children and adolescents as they navigate through life. So Miss Faith, if you can hear me, you have the floor. Thank you.
Thank you very much, Dr. Vanessa. Unfortunately, I cannot turn on my camera. I'm in the environment where the internet is not very stable. I've heard all these stories, all the scenarios from the cases that you just presented, and they were really very much interesting. But let me go straight forward to what is child protection. I think we all know child protection is all about making sure a child is safe. Yeah, it refers to the prevention and responses to abuse, neglect, exploitation, violence, harmful practices against children. Sometimes people confuse gender-based violence with violence against children, but violence against children has its own principles. Yeah, the key principles, as one of the members just mentioned, includes best interest of the child. That is, whatever we do, whatever we think emotionally, whatever we do physically, whatever we do sexually, has to be for the best interest of the child. Does the child feel safe? Does it consider the child's mental well-being? Does it consider the child's interest? So the key principles are best interest of the child. We have non-discrimination. We have right to survival and development. We also have child participation. So from all these cases that we just discussed, you can see where the child is coming in. From the case that we heard from the first time, can you see the best interest of the child? Can you see the non-discrimination? Can you see the right to survival and development? Can you see a child given a chance to participate in decision-making, and so and so? So we have different legal frameworks that we use, and to making sure that the child is safe and the child is protected in all areas. And these they are universal. For example, we have the United Nations Conventions on the Right of the Child. We normally call it the CRC. We have the African Charter on the Rights and Welfare of the Child. But also in Tanzania, we have Law of the Child Act of 2019. We also have the Constitution of the United Republic of Tanzania. I wouldn't love to go deeper into the legal frameworks. I would rather have a little discussion on what we just heard. In Tanzania, for instance, we have something called the referral, the escorted referral. Social workers, whenever they meet a child or they get access to a child who has high viral load, that to us is a very, very big case, because the first thing we ask ourselves, why is the child having high viral load? If is being taken care very well at home, if the caregivers are aware of the do's and don'ts, if the caregivers escort the child for medical care, So whenever we hear about high viral load, we normally call it HVL. That is to us a major issue of concern, because in most cases you find children who have high viral load, there are issues at home. And in most cases, children with high viral load are taken care of either at some point there was a caregiver who was not a biological parent. We have had numbers like 80 cases where we find children with high viral load include children who are under foster care or children whose parents are away or orphans and vulnerable children. So this calls for a lot of discussion. Why do we have these cases to children whose parents are absent? You know, for example, for the first case, it really got into my attention that at some point the child is just 5 years, but there were a point in his life where he was not taken care of by his parents, and the mother is still not ready to disclose her HIV status. And you can see when the mother is absent, what will happen to the child? Will this child be safe? Will this child have proper adherence of the ART? Will this child have proper nutrition? So you can see when we talk about child protection, it's not just about the issues of a child at the health facility. If we really want to ensure that a child is safe on these HIV issues, we really need to go back and visit homes. We social workers normally have something called home visits. Whenever we notice that there is a problem of a child, whether in their health, whether they are not attending schools, or whether they get very sick, they get sick often, or whether there is violence or there is abuse, the first and foremost thing, you need to visit home. At home, you are able to conduct something we call social investigation. You can see and notice a lot of things that at the facility level you cannot be able to understand. So one of the things that I really wish all of us to take into great consideration is that we go to the families of these children. When you're at the family level, that is when you are able to observe and also note issues that you think something just popped up, all right, that you think you can take action. But another thing that I think we should all take into consideration is screening of violence and abuse at health facilities. Sometimes, you know, when the children attend healthcare institutions, the only thing that the medical personnel just look at, you know, the baby has fever, the baby, the weight is down, the weight, you know, the baby is not doing well, the baby is coughing. But what about social issues? Is the baby happy? Are you looking at the baby? Is he or she charming enough? Do you see the baby active? You know, so the screening, we have tools, you know, that can tell you, we have those 5 questions that can tell you that this baby, apart from the fact that they are not well on their health, but there are also social issues that could be indicators that the baby is not well at home. So I think it's very important that when we look at a child, we look at the whole holistic approach. You look at the health level, but we also look at the social aspects, you see. But another thing, we also have the social welfare system has social institutions. For example, we have safe houses, you know, for those children who experience abuse at their families. It's not a good thing to withdraw a child, but sometimes when it's necessary, we normally advocate for a temporary withdrawal of a child so that we stay away from the family with the child and making sure that the child recovers and the child is getting back into normal before other procedures. So I would also recommend for children that you meet that you find they experience a lot of issues at home, specifically abuse or violence. Sometimes we really recommend that we take a child away from home for a while as we take care of the problem to save the child from such abuse. But we also have children's home. Other countries call it residential houses or residential homes, where children in need can temporarily be placed and get all the needs as we take care of the families at home. For example, I was considering the mother who was not ready to disclose. what if she gets pregnant now? What if she does not exist anymore? What if she dies? Or what if the family no longer exists? What will happen to that child who nobody knows his health status, you know? So I was thinking sometimes when we meet critical issues, it's best for the best interest of the child, we remove either the baby or the person who is harming or tormenting a child for a while so that we have a safe child. But also I was thinking it's very important, for example, the case from Nigeria of adolescent who started substance use, alcohol. We also have something called methadone alternative care or alternative therapies for adolescent who has been into use of alcohol, sometimes, sometimes even marijuana or other stuff. We recommend that we take them to methadone alternative therapy. It's very important for them to change because it helps them to change their behaviors, and also we also give them counseling that eventually makes them better people, and it also helps in adherence. So my concern was whenever we see HVL, whenever we see high viral load, it is time for us to ask ourselves what is happening at home. As a social worker, it has been like a routine, if I can call it, that most of the times HVLs are associated with neglect. Sometimes they're associated with violence, and sometimes they're associated with abuse at home. So whenever you see that, we kindly ask you to take extra precautions and extra measures into making sure that our children, and adolescent in this matter, are safe and to visit home. But also sometimes we have people we work with, they're called community case workers and community health workers. For those with high viral load, for instance, we can always escort them. Sometimes not necessarily for a parent to take fully responsibility. Sometimes we pay them a little fare, bus fare, to take a child to the clinic and return the child so that they can suppress from HVL. And another thing, I think it's very important to create a good environment for these children so that they can share what they experience, to create a good rapport, to ensure them of the confidentiality of the information they share, but also show empathy and sympathy, and sometimes also to invite, a good environment for them to be free to express the environment so that we can be able to save them sooner than wait for them to be HVLs or to be violated. Then we start asking what happened, why are your kilos dropping down, or why are you not happy? I think it's better we invest in prevention rather than response. So that is what I wanted to mention on child protection, is that we ensure a child is safe in every aspect of their lives. And there are several indicators that can show you this child is not safe. And one of the things are the things that have been discussed here. There is malnutrition, a child is not going to school, there is truancy, a child today goes to school, tomorrow does not go, or a child goes to school, and we have been noticing this, that the child goes to school, but she goes to school without eating food in the morning. And they are telling her or him, for you to have a good adherence, you need to take medicine. And we all know those medicine are, I don't know how you call it medical. They bring a lot of tiredness and they make you hungry. So the child decides not to take medicine. They throw the medicine in the streets so that they can be okay. So I think the last thing here, which we should all consider in the matter that we want to make sure that we have child protection, is making sure we strengthen these families economically. When we look at these issues that we have been presented here, most of the families, with high viral load, families with HIV disease, you might find their economic status is very low. As I mentioned earlier, children go to school without taking anything. You know, they sometimes they only have one meal in a day, and there is no education on proper nutrition. So as we take this thing into the broader perspective, it's very important that we consider other issues as well, issues of economic strengthening of the family. We can go to the families and educate them on proper nutrition, proper foster, issues of child protection, adherence of ART, escorted referrals, and sometimes even just visiting their families and have a good time with them. So I think this is all I had. And I would love to congratulate you all for a very good discussion. Thank you.
Yes, thank you so much, Faith. I can see Vanessa is dropped off, or Vanessa, are you still there? And we really appreciate for the insight on child protection, as well as on advice on how we can deal with these young people and children who really struggling even within their family, and how we can connect with the social welfare system and support them in different ways. So thank you so much. And if there's any questions that burning questions that anyone wants to ask, then they can either put it in a Q&A, and as well as share it in the, or they can speak up. I can see Uyomosi is raised their hand. Can you please go and talk about this?
Yeah. Thank you so very much for this again. And thank you very much for this insights around child protection. I'm raising my hand just to be able to, I think I put a good number of things on the chat. I have put a good number of things on the chat, which are things we do here in Cameroon to support child protection. So we have policies. I think that one of the things that we can do as service providers for adolescents and child and adolescent HIV care is that we could actually be able to have child protection policies or safeguarding policies that can be able to help us see how we can conveniently integrate child protection in the pediatric care for these children. In that, we equally have we have produced, and we are using commitment forms, child protection commitment forms, where even parents, when they come to services, we start making them understand the need for them to sign undertakings on their readiness and availability to provide the needed assistance that the hospitals will need to ensure that the child's safety and protection is guaranteed. We have also to understand the need of not waiting for the case, for us to see high viral loads or defaulted cases before we start thinking of integrating child protection or social actions. Sometimes the social actions or child protection integrations, they come way later when the hospitals are finding it difficult. But rather, if all of these things are integrated at the very beginning of care for an individual, I am sure at least we will be able to move a little bit faster, and maybe the outcomes will be better compared to when social or psychological support starts coming at the point where we already find difficulties managing those cases. So integrating at early stages is another way of making sure that we can manage it very well. Again, having this opportunity for the presentations is a very good way, because in doing this, we are able to get expert knowledge at different angles and seeing what works where, so that we can support. And when I look at these two cases that we've mentioned today, we'll really see that there's an issue which is almost always around poverty. Poverty seems to be one of the key factors that may cause our children not to have access to or not to have proper follow-up for their medications or to ensure that their viral loads are managed properly. So if there are things that we can do to really improve on the economic aspects of children is very important. Just to add my voice again to say that when we are looking at the assessment tools for child abuse, or if we don't have them, it's important that those things are integrated still within the package that we provide at the level of our hospitals. This way, we will be really into a preventive than responsive support, because honestly, sometimes the risks of these children increases. I got one of us talking about how the child of 5 who already attends a kindergarten, how there could be a continuum of care at the level of the school, or the center where the child actually goes. There are lots of risks, which again, I think that there is need for further risk assessments within our community structures where the children are going to school, to see the implications of disclosure and how it can be managed in ways that the child does not finally get exposed to further harm, because further harm would mean that the child may end up in a worse situation. So there is need for integration. There is need for us to see how we develop new strategies and combat these issues even as early as when a child is just diagnosed. If all the team can come together, I'm sure it's going to make a huge difference, and we will have more time to build the children than to support the children grow better or rather than waiting until when it has gone off hands and we are struggling to see how we can get them back on track. Thank you so very much.
Thank you very much, Madam Maureen. I think she's made very valuable contributions. And just to allude to the fact that in one of the clinics where we worked, we had a lot of issues with children or caregivers not paying attention to children. And we brought Madam Maureen. And I remember after what the law was saying about the neglect they were providing to the children, or they were exposing these children to, and the fines that could come because of that. We saw an improvement in the way children were being managed, or the way caregivers were responding to the needs of their children. So I think it's something that we can do. We can have the commitment forms. We can have sessions with parents where we have these child protection experts come and speak to them, let them understand the dangers or the implications of what they are doing and the possible punishments. We don't want to make it seem like we're going to punish them, but let them just be aware of all of this. Thank you very much to Madam Ms. Faith and Madam Maureen. Sorry, Ms. Faith, when you finished, my network was out. Thank you very much. At this point, I'm seeing that we've gone above the time that we stipulated for this session. But notwithstanding, I want to have our panelists give us last words. I know some people
I can see that Vanessa is cutting, but what?
In the Q&A, and they have been responded to, and there have been some discussions in the chat as well. Thank you to Dr. Nandi. Can you hear me?
Yes,
hello.
Vanessa, you were chatting.
Okay,
yeah. You were
saying that I'll give the floor to Dr. Nandita.
Okay, cool.
Okay, thanks so much, everyone, and for staying on. And I think we could go on for hours talking about these cases. think what we've learned is that HIV is beyond just health, right? And so I think when we talk about now the primary health system, we're thinking about a whole of society approach. And some of these issues around child protection, social welfare, that's a whole of society approach. And so on one level, I think healthcare workers take on a lot of the burden themselves. We shouldn't be pushing it on to the peers either, but there needs to be a social, societal approach to this. This is where the community programs become very critical. So I think what we need at this moment in time is advocacy. I think God Power made some very good comments that, the resources sometimes aren't there. And we know now with our latest round of funding cuts that many of the child protection services, many of the social welfare programs that were previously provided through OVC programs have fallen away. And that's not to say that healthcare workers have to fill the gap, but somebody needs to. And this is really the role of government. And so this is, again, a call, I think, for all of us to pay more attention to these issues and to really advocate for those systems, those protective systems to be in place. As Madam Maureen was saying, we don't want this to be a punishment, right? When we talk about social services, and I'll say even here in the US, families sometimes do see it as a threat or they're worried that their child will be taken away. So again, this has to do with the relationships we also build with our clients, with our families. And so again, I really want to thank the teams that put these cases together and for all of you for following these children with such dedication. Many of the interventions that they actually need are not interventions that we can buy or sell. They're interventions that we give through our attention and caring. And that's really one of the privileges, but one of the challenges also of being a healthcare worker. So I really want to thank PATA for putting this together, for giving us a chance to talk about these issues and look forward to the next PATA Reel. Thank you.
Thanks, Dr. Nandita. Okay, very quickly, we'll hear from Dr. Filuka. Just your last words. Thank you.
Yeah, I appreciate. Thank you so much for the cases as well as for the discussion. And one take home that I have right now is just to be able to start early.
Oh, unfortunately, we lost Dr. Filuka. Network, I guess. I guess I told you it gets real. Okay, Madam Maureen, your last word. Thank you. Just last word, quick word.
Quick, thank you so very much for PATA Reel. It's good that I was part of this. I've learned a lot, and there's a lot to be done for our kids. Remember that the next generation needs to be empowered so that we don't lose out on the kids that we are working so hard to keep. My pleasure, and hope to be in another session to discuss more and have more insights. Thank you.
Thank you. Thank you again to all our panelists, Dr. Nandita, Dr. Filuka, Madam Maureen. Thanks to our case presenters, Ms. Faith, Dr. Ruth, Ms. Agnes, and to all people who support to make this PATA Reel a reality. I want to thank the team that supported to put the cases together, and also really to thank Angelita and the translation crew. You guys are always so amazing at making sure we have the best PATA Reel possible. We've just come to the end of our sessions for today. And we look forward to having you again in our next session. We do apologize for the challenges with the Zoom app, but we are sure that we are going to count for the links and be sure to invite as many people as possible, just so that we can have the best way forward for all our children and adolescents. Thank you for staying on. Thank you, Team PATA, for always giving us a wonderful time. Until next time, bye.
Bye-bye. Thank you so much.